name's Matt Shuba. I am one of the critical care medicine staff. I'm also the APD for one of the APDs for the critical care medicine fellowship. And I predominantly work nights. So you will all see me at some point when you come to the darkness. So today I'm going to be talking about a couple of things in particular. My goal, I accumulated and amassed the slides from everybody that spoke today so I could get an idea of what people were talking about, including Glenn Hernandez, to make sure that I didn't overlap and to make sure that I can kind of have this serve as a summary for the day, because I know everyone did presented some outstanding content today, and I just kind of want to bring it together. This talk is also kind of a talk within a talk, because I'm also going to talk about non-invasive hemodynamic monitoring. But when we think about endpoints and septic shock, the first thing we have to ask ourselves is, what's the ultimate goal? And I mean this in sort of a lofty way, because a lot of the time we get focused on numbers. If I have septic shock and I get admitted to your ICU, my goal is to end up in a place where I am still healthy and functional enough to be able to go to a place like this and sit on a boat like that. If I can't do that, then I'm going to feel a little bit like maybe, this was not something that was goal concordant for me. This is a really hard thing to measure, though. So what do we measure? The first thing we measure is alive versus dead. And generally speaking, we agree that being alive is better than being dead, though I'm sure there's some extenuating circumstances when that is not the case. We're really not even that good at measuring what leads to that. So we end up with a bunch of surrogate endpoints, and we hope that they point to mortality. But in a lot of ways, our surrogates end up pointing to other surrogates. So normalizing a parameter may make you have less ventilator days or have fewer vasopressor dependent days, but that may not necessarily connect you directly to mortality. It may be loosely associated with mortality, but not in a way that you can actually say that that's something that matters. And remember, when I'm talking about mortality, I'm still not reaching my goal of being healthy, functional, everything else. But this is the world that we live in, but I think that context is important. When most of us think about how to treat septic shock, we think about macrocirculation, we think about microcirculation, but we think about it pretty much confined to these two parameters. If I make the MAP good and I make the lactate low, everything is going to be fine. Well, there's a really nice quote that attaches the significance of that to reality pretty well. There's always a well-known solution to every problem that is neat, plausible, and wrong. If we view the expanded universe of perfusion markers and resuscitative endpoints, we see there's a lot more information that we could potentially be gathering. There's certainly not time to talk about all these things today, but I think it's important to know that this is a piece of the landscape of resuscitation and endpoints of resuscitation. When you sum all these up together, I think we can kind of group them mostly into three categories that we think about on a level that we can understand in a patient. We think about flow or cardiac output and the adequacy of that. We think about vascular tone, and then finally filling pressures. Not only adequacy of filling pressures, but also looking out for congestion or looking for safety parameters when we're resuscitating patients. This framework, flow, filling, and tone, you'll see again, because it forms the backbone of our diagnostic algorithm for shock that we will roll out in the MICU here pretty soon. And you will all be utilizing this as part of a multimodal approach to the patient with shock. But you see, the general approach here is to try to estimate cardiac output in a couple different ways, estimate at least right-sided filling pressures, and then try to estimate what you think the tone is. Now, this diagram we use predominantly for diagnostic purposes, but as you can imagine, altering these parameters may also potentially be therapeutic endpoints. And those are things, or at least safety parameters. So those are things that we'll talk about as well. So the first thing is, where should we start? How do you operationalize these things? And where, how do you actually take that information and apply it to a patient? Well, I know Glenn Hernandez already talked to you today, and he talked about in some ways about Andromeda shock. But this algorithm for Andromeda shock, which they used in both arms of the trial, I think is a really reasonable framework of where to start assessing the patient with shock. As you recall, in this study, they evaluated cap refill versus lactate as perfusion markers. And we'll talk about which one makes more sense in a second, but the flow that follows really makes good sense. And we'll talk about each part in turn and how we might apply it in our own personal or in our own particular setting. I also want to point out, I use QR codes for references. So if you want to see anything that I'm referring to, just take a picture of the slide or a screenshot of the slide, and you can find, it'll link you to the website instead of having to try to scramble and write it down or something like that. The first thing we need to do when we're dealing with a shocked patient is do a global assessment. This is the check engine light. For most of you, that's measuring lactate. And I guess that's fine. I think there's a lot of reasons why this is a reasonable test. It's associated with, worse outcomes with higher numbers. As a perfusion marker, it probably has a lot of limitations as far as having poor sensitivity and specificity. A lot of times a fellow or resident will tell me, well, the patient's lactate's only 1.8, so I think everything's okay. I said, okay, well, they're on escalating doses of 3 pressors. I don't actually feel much better about this situation. So maybe there's a better way to do this. Turning back to Andromeda shock, most of you probably paid attention to the Kaplan-Meier curve and the p-value of 0.06 and said, okay, well, cap refill doesn't work. Well, it's at least as good. It's probably better. And to show how it might be better, turn to the Bayesian analysis done by Fernando Zampieri and company. Here is a alluvial plot from that study showing that the changes in SOFA scores over time favor peripheral perfusion over lactate driven resuscitation. And this diagram at 3:12 in the afternoon is probably going to make everyone kind of sick to their stomach because it looks like statistics, and it kind of is. But this is a Bayesian analysis and showing how the results of Andromeda shock should change your posterior probabilities based on what your pre-existing beliefs in work comparing cap refill to lactate. And no matter what your prior was, pessimistic, optimistic, null, neutral, a capillary refill based strategy seems to be favorable. But you have to do it the right way, and you have to do it the way that is consistent and going to be delivered the same every time, because otherwise you're going to bias yourself in one way or another. I actually carry around microscope slides with me. They're like $10 for 50 of them on Amazon. But if you don't want to do that, you at least have to make sure you blanch the finger for a full 10 seconds before you release the pressure and interpret the results. And in the Andromeda shock trial, they actually measured it with a timer to see the time to returning to normal. And, I have an Apple Watch. Probably a lot of you have watches that can time this. So this is an easy enough thing to do. But my recommendation, we live in a world where lactate has gained a lot of importance due to core measures, and you're going to have to measure lactate probably twice. But after that, I think capillary refill has a lot of appeal to it. Not only are the outcomes potentially better, but it's probably a better reflection of coherence of circulation. So this is our step one, checking engine light. The lactate is abnormal or the cap refill is abnormal, and I'm going to do something about it. The first step in the algorithm is looking at preload responsiveness. I know Sid talked about this in some ways when he's talking about echocardiography to assess fluid responsiveness. But remember, in the end, the whole goal with giving somebody fluids is to raise their stroke volume. So then the first thing you have to decide is this somebody that's likely to benefit from that? Do they have adequate cardiac output? And what the heck is adequate cardiac output? We'll talk more about that later, but that is the pre-test question you need to ask yourself before you assess a patient in septic shock, because the majority of them should have normal or high cardiac output. But when you do your echo and gather collateral information, you may find out that that's not the case. And there's other parameters that we'll talk about that may help you assess its adequacy. Something that's really important to me is to talk about the natural history of fluid responsiveness. So this is from the supplement to the Andromeda shock trial. These patients were enrolled either arm after they got on average about 25 mLs per kg of fluid. So this is hour 0, 2, 4, 6, and 8 after they've gotten their initial resuscitation. So you can see at hour 0, maybe about 60% of the patients are still fluid responsive, but that number rapidly diminishes. So if you're seeing a patient who's in 2 or 3 pressure shock and it's like 10 hours later, and there's a fluid responsiveness parameter that's positive, you should consider whether that actually is a true positive or a false positive. But it's something to think carefully about. Fluids, I think, are probably the most over-administered medicine because it feels good to do it. And sometimes you see the blood pressure go up for 15 minutes and then you think that there was a positive response. But realistically, a lot of it leaks out into the interstitium and then we're back where we started again. But, by the morning now we're 6 liters positive, which makes me a little bit dead inside. So remember that when you're giving somebody volume, your whole goal is to raise the stress volume, to raise the venous return so that you can increase the stroke volume. So A is the pre-resuscitated condition. Part B is I gave fluid and it actually did result in venous return, which is like a miracle in septic shock outside the first couple hours. And then the last point that I want to point out is, you can also just change the size of the tank and increase the stress volume that way by way of giving vasopressors, which obviously makes a lot of sense because we're talking about patients who are vasoplegic, and it makes sense to directly address the issue at hand rather than try to fill a tank that's probably continuously leaking. But anyway, At the outset, it's reasonable to assess fluid responsiveness. After that first initial period, you should really be looking at other ways to hemodynamically optimize your patient. However, while we are administering fluids, we need to think carefully about the safety of administering further fluids. How do I know I'm going from being helpful to being harmful? I will tell you that if you wait until your patient becomes hypoxic and develops pulmonary edema, it's too late. You waited too long and things have already gone in the bad direction. And now you're going to have to walk back what you've done. So what are some easy safety parameters to be able to assess when we're thinking about stopping rules for fluid? Well, the easiest thing is to measure the much maligned central venous pressure. And now everyone is going to wonder, is Matt kind of a quack? Because I thought central venous pressure doesn't really have a role in the resuscitation of a septic shock patient. And you're right, it's not a target for resuscitation. It is a reasonable target to consider. I've gone too far and I need to stop and I should not give any more fluid and maybe I need to start taking some away. What I'm showing here is a rate of acute kidney injury, new or persistent, rises significantly once you get above a central venous pressure of 8. This is a rough guide, but it's somewhere to start. And there's other studies that show a positive fluid balance in septic shock is associated with worse outcomes, even when you adjust for severity of illness. So you can't just say, well, they got the fluid and their CVP is high because they needed it. Realistically, we need to be a lot more fluid sparing in these patients. And if you're using dynamic parameters of preload responsiveness, you'll probably avoid this problem. Note, though, that this range of central venous pressures where the AKI risk goes high is like what Manny Rivers told everybody to do. And then everybody did it for like 12 years. And maybe that wasn't the best idea in the world. So I'm hoping now we're in a post-Rivers world and we can not resuscitate to supraphysiologic endpoints. But this is a good example of a potential stopping rule. There's a really nice editorial about this. I really recommend reading this. This is obviously not a study. It's not a randomized trial. It's not even an observational trial. This is 3 smart people giving their opinion on this issue. But something that's really an important takeaway from this is if your right atrial pressure is rising and you can't show me that your cardiac output rose, you likely did harm. You likely congested this patient. So again, I think when you're in that range above CVP above 8, you need to really think twice about what you're administering to patients. Or if the CVP rises by more than 2 or 3 and you can't show that your cardiac output rose, you should also consider that's maybe harmful. The right ventricle distends really, really easily. And so once you see that CVP rise by a couple points, if it's not resulting in forward flow, it is resulting in RV distension. And then for the ultrasound enthusiasts in the crowd, the VEXA score or venous excess ultrasound score is another way that you can assess systemic congestion. The worsening of this score, which you can see going from left being normal over to the right, the most abnormal, the more abnormal this score gets, the more likely you are to develop acute kidney injury. This has predominantly been studied in post-op cardiac surgery patients, but those of us who have adopted it at the bedside have seen that this is something that actually probably should play a role at some point in the future. And there are studies planned and pending to assess it prospectively, so we'll see. But in the meanwhile, it's hard to assess congestion, but you kind of at least have to be a bedside physiologist and figure that out. So now that we've moved past the point of preload responsiveness and preload safety, we can look at MAPgoals. And I know this has been talked about a little bit by people before me today, but it's worth revisiting now because this was something that was systematically tested in patients with previous chronic hypertension in the Andromeda shock trial. Let's step through a couple of the studies quickly just to summarize them. I know that some of them have been mentioned already. So sepsis PAM is the first one where they compared higher to lower MAP targets. There was no mortality benefit, but there was less AKI in the group with chronic hypertension, but of course there was also a higher rate of arrhythmias. The 65 trial, which compared a more conservative MAP goal of 60, between 60 and 65 compared to traditional management, showed no difference in mortality or AKI and suggested maybe a MAP of 60 is okay for patients that are at 65 years of age or older. But remember that they did not show any subgroup benefit to increased MAP goals for people with chronic hypertension. So now what do we do? It's really hard to say. Well, it seems like we're probably gonna have to personalize this a little further. This is a really neat observational study. It's from the MIMIC database. If you're interested, you should read it. But this looked at time of relative hypotension, which was defined by a renal perfusion pressure, which is MAP minus CVP less than 60. And the longer period of time that you spent with relative hypotension, there was a higher rate and duration of AKI. Really neat study. Check it out if you're so inclined. And then finally, in Andromeda shock, the vasopressor test, which I showed in the diagram, they raised the MAP to 80 to 85 in both arms. And between 38 and 44% of the patients with chronic hypertension normalized whatever their endpoint was, whether it be lactate or cap refill, when you increase their MAP goal. A couple of things I want to point out that's important about that. Number one, this kind of makes sense from an autoregulatory standpoint. If somebody's used to living in a higher range, they may lose the ability to autoregulate blood flow to their organs once they get to what would be not that hypotensive for you or I. The other thing is in Andromeda shock, they only tested these things for, an hour or two, a couple hours before they decided if it was helping or not. And if it wasn't helping, they returned to the prior target. So it's not like sepsis PAM where the target was maintained for a longer period of time. It was actually targeted to some sort of an endpoint. So if it's helpful, you keep it. If it's not helpful, you throw it away. Finally, talking about macro flow, cardiac output, et cetera. In the Andromeda shock trial, they did it as a simple binary test. I'm going to add a ninodilator and see if it normalizes the lactate or the cap refill. That's probably not an unreasonable way to go if you're in a low resource setting. You don't have the ability to test things a little bit further, but we do, so we should think about it in a little bit more depth. And for that purposes, we'll turn our focus to non-invasive hemodynamic monitoring. So then we return to that question: what is adequate cardiac output? I don't know without assessing a patient first and seeing how the interventions that we try change parameters, and we'll talk about this some more. A normal index is probably somewhere between 2.5 and 4. But our goal in the end is really to have adequate flow so that we're oxygen supply and demand are well matched. I think Samir alluded to the veno-arterial CO2 difference, which is a really neat way to assess adequacy of flow. By flow, I mean cardiac output. And by cardiac output, I mean it could be cardiac output is low from a cardiac issue or from a low stroke volume, and that's for you as a treating clinician to find out. But this is the relationship between cardiac output and the delta CO2. Higher numbers are associated with lower cardiac output. The sort of relative stasis of venous blood flow causes the blood to pick up more, the venous blood to pick up more CO2. So by the time you measure that central venous PCO2, it's much higher than the arterial PCO2. Sorry, there's a typo on that slide. It should say arterial PCO2. As an example of this, last night we were consulted on a patient in J31 who had a SWAN in place, and we were consulted for hypoxemia. And in J they do their gases paired together, so it's kind of a nice way to assess the CO2 gap. Well, in this particular patient, they were only in low-grade shock. They were on like 6 or 7 in norepi, but they were receiving enough PEEP to put them into RV failure. So their cardiac output was actually low. So their delta CO2 was like 13 or 14, and we dropped the PEEP down to a level that wasn't over distending, and all of a sudden it was 5. So there's a lot of applications of this, not just looking at the septic shock patient, but looking at people where you're trying to assess adequacy of flow. And sometimes this is helpful if you can't get echo pictures on someone, or you're just trying to confirm what you saw with echo or with some other monitoring device. This is a really nice underused tool. I wouldn't get it. Again, I don't think any of these values I'm talking about today are something you should trend at any specific interval. These are the things you should do when you have a clinical question you're trying to answer, or you provided a therapeutic intervention. You want to see if there was a benefit to it. Well, let's talk about other ways to actually at least crudely measure cardiac output, non-invasively or minimally invasively. I know Sid already talked about LVOT VTI, so I don't want to delve into it too much, but this is a good place to start. It's non-invasive. It doesn't require any special devices. There is so much to talk about minimally invasive cardiac output devices, and it's really too much to cover today in the scope of this presentation. So I'm going to highlight a couple things, but Aman did a really nice module on this for the hemodynamics course, which you all will get in January. But if you can't wait, just ask him to send you his slides because they're really sharp and you can pretty much follow through without having somebody narrate them to you. So this is example of 4 different type of devices that you may encounter that are, some are calibrated and some are non-calibrated. And as you can imagine, the calibrated ones have probably a better fidelity to tell you what your actual cardiac output is. So one example is lithium thermodilution, the classic LIDCO device, not the LIDCO we have in the unit. I'll talk about that in a second, but the classic LIDCO device where they actually use lithium thermodilution to calibrate the device and determine cardiac output. And then there is another technology which I'll discuss called transpulmonary thermodilution. The most popular device that this is used with is the PICO monitor, which I'll show you in some more detail. Non-calibrated devices. Bioreactance device that's most popular is the Cheetah, which was used in the FRESH trial, and you will see at all the major conferences because it must be really expensive because they always have like the biggest booth. But that's the one that just uses the external, cutaneous pads and uses phase shifts to try to determine cardiac output and preload responsiveness. And then there's the pulse contour technologies, which depend on proprietary algorithms. One would be the Vigile or the FlowTrack. The other is the LIDCO Rapid, which is the device that we have in our unit right now. So as of now, we have 2 of these devices. There are 2 ways to use this device in terms of how to hook it up to a patient. One way is if you have an arterial line, you can plug this device directly into the tram that hooks up to the patient monitor in the room. That's probably the highest fidelity way to use it. It also comes with these finger cuffs. I will tell you that in a patient with shock, they are approximately useless. I've never actually gotten any numbers of fidelity. I've used them in simulation when we do hemodynamics day, and they work great on healthy fellows, but they don't really work well on shocked patients. So how do you use this device? Well, you can see there's a number of parameters that are reported. Some are related to preload response, some are related to raw estimation of cardiac output. My opinion, my recommendation to you would be to use this device really, really cautiously. Number one, this is an uncalibrated device. So I would not use this to report off raw numbers of cardiac index to anybody because again, it's not calibrated. I'm not sure what the reference point for that is. Now, it is possible to calibrate this device to an external source of cardiac output. So if you did get a really high fidelity LVOT VTI and you calculated the cardiac output with that, you could input it into this machine and it would adjust the numbers that it's giving you up or downwards, depending on how different it was. I think this device is fine to trend the cardiac output or cardiac index, and also just to see how the delta is when you make an intervention, change vasoactives, give fluid challenge, something like that. That's probably reasonable. These measures of preload responsiveness, like stroke volume variation, pulse pressure variation, as you probably already know, are only valid in a passively ventilated patient and sinus rhythm who is breathing 8 to 10 cc's per kg tidal volume and sort of has normal lung compliance. So it's like there's a lot of limitations to it. So I would more use this for gross trends than actual finite numbers. And part of why our shock protocol is built the way it is, because you should not probably use any one device or any one number to determine if cardiac output is adequate or not. You should probably use at least 2 different methods in order to make sure that there's coherence in the data that you're getting. Now, to look at a calibrated device, this is the Pico monitor. We do not have this device at this period in time. We're trying to assess whether it's something that we should add. It involves a central line and, generally speaking, a femoral arterial line. It uses cold thermodilution in order to calibrate and to measure cardiac output. But there's a number of other parameters that you can measure with this device, which could be helpful, especially in managing patients with ARDS, right ventricular failure, things like that. The reference for this slide is pretty high yield. That's where this diagram came from, and there's more information in that particular paper. In the end, though, like I mentioned, make sure that whatever numbers you're getting are coherent with some other number. So don't just measure a VTI, because if your angle is wrong, then that's going to be, the validity of that will be threatened. Don't just measure non-invasive cardiac output. These are all things that need to be corroborated with something else. We can say that maybe the PA catheter is the gold standard in this case, but we all know that there's no such thing as a perfect device. So the more things that you can get pointed in the right direction, and especially if it lines up well with how does this patient respond to the interventions I give? If I give something where I expect their cardiac index should rise, does it actually happen? That's the kind of coherence I'm talking about. So there's no one perfect number. There's no one perfect device for any of these things. What I can say, though, is the higher the severity of illness goes, and I would pair that with potential reversibility, or the higher your diagnostic uncertainty goes, you probably should think about more invasive options as time goes on. So that doesn't mean if somebody has metastatic cancer and is on 3 pressors and is too unstable to even tolerate CRRT, I'm not sure that's the patient that I put the PA catheter in. But if you think you've got somebody early in the course and you can't otherwise determine what the cause of their shock is or whether you're making an impact on it, then I think it makes more sense to be more invasive. Maybe more invasive means a central line with measurement of the delta CO2 and the central venous oxygen saturation. But in some cases, it might mean something more complex than that. It might mean transpulmonary thermodilution. It might mean a PA catheter. This is a really nice document. It's from 2014. I have to imagine there's going to be an update coming soon because they update it about every 7 years. Consensus on circulatory shock and hemodynamic monitoring. Most of what I said today, I think, is pretty well supported by that. They don't hit as hard on the capillary refill because the Andromeda shock hasn't come out yet, but I imagine that will gain some prominence as when this is updated. So to bring it all together again, when you're thinking about the shock patient, I think it's reasonable to think about these parameters, but also think about how the people that spoke to you today gave you a framework on how to optimize those parameters. If you're trying to figure out how to optimize flow versus tone, think about the lessons that Seth gave you when he was telling you about how to rationally choose vasopressors. When you're trying to assess flow and adequacy of output, think about what Sid taught about echocardiography and non-invasive assessment. When you're trying to think about adequacy of output, think about the things that Samir talked about when talking about central venous oxygen saturation. And then when you're trying to put these all together in a system, think about things that work and things that we know are less effective, like were talked about by Ryota and by Ahmed. And when you're trying to optimize tone, this is a place where maybe steroids come in, as was talked about in depth by Aman. And then finally, I think Glenn put it together very nicely. You have to think about perfusion in a way where you're trying to optimize flow and not compromise it by adding congestion to the system, but also just kind of think about these things in phases. The patient at hour 0 is very different than the patient at hour 36. So context is everything. Whenever you're approaching these issues, as long as you're being physiologic, systematic, and rational, you should be pointing the patient, generally speaking, in the right direction. There's no perfect paradigm for how to treat the shock patient. I hope today that I provided you with some clues that will help point you in and help give you a system and a framework for how to address this. Remember, though, that you're trying to get the patient to where they want to go. And if it's not achievable, all the normalization of numbers in the world is not going to get somebody where they need to go. So make sure you understand what the patient wants and what you think you can provide based on the information in front of you. For both treating hemodynamic parameters and for goals of care, context is everything. Thank you.
Thank you, Matt. Just going back to that diagram you showed, the Andromeda shock fluid responsiveness one. Just trying to, so obviously, that was post initial fluid loading, and then in a few hours, there was a significant drop in the percentage of fluid responsive patients. Were those, I'm sorry, I haven't gone into the details, but did those patients get more fluids in those few hours, or it was just that their physiology changed?
That's a good question. The fluid, it would have been nice to see that fractionated between the cap refill group and the lactate group, because the cap refill group did get slightly less fluid overall, but it wasn't that big of a difference. It was statistically significant, but it wasn't that big of a difference. It was like 500 cc's difference. So I'm guessing it's because the physiology is changing, but as somebody who practices in an ICU with people, with other people, that probably there's ongoing fluid resuscitation despite absence of responsiveness in some cases, but I think the protocol adherence was pretty decent. So I'm guessing the physiology changes. I think you're in that sort of, I think as Glenn probably talked about, sort of this sluggish flow responsive state initially, and then it's funny how fast that probably goes away.
Great, thank you.
Well, thanks, Matt. If anyone has any other questions, this is your chance. Otherwise, you can reach out offline. And congratulations to those of you who survived your first education day. This one was, I think, particularly good. And I want to thank especially all those who